Welcome to Health Policy, Organization, and Finance. This is your Week 8 video. Week 8 is all about the uninsured. Last week we talked about acute care, we've talked about long-term care, we've talked about the different types of insurance, we've talked about how healthcare works generally, and some of the major policies. This week we're going to talk about the uninsured, but there really isn't a policy for the uninsured for folks who need care in the U.S. other than EMTALA. EMTALA is really a policy that is meant to impact the uninsured population in the U.S. EMTALA was enacted in Congress in 1986, and it's part of the Consolidated Omnibus Budget Reconciliation Act, or COBRA. You might have heard of COBRA as part of a package of insurance that you can get if you lose insurance. EMTALA was basically part of this. EMTALA is a federal law, and it applies to hospital emergency departments. At its most basic, EMTALA requires that emergency rooms screen every patient who comes in seeking emergency care. The rule requires stabilization or transfer regardless of health insurance or status or ability to pay. So basically what EMTALA does is it provides care for those across the country whether or not they have insurance. That's why I call it the uninsured policy. So we'll be looking at EMTALA this week. So who does it cover? EMTALA really covers everybody across the U.S. Anyone who's in the country, whether they're a citizen, whether they're not a citizen, whether they're here under immigration status, whether they have a green card, whether you're here on vacation. EMTALA covers every single person. The requirement for EMTALA really isn't based on who you are. It's based on whether you're having an emergency medical condition. And that's defined really within the statute. And I've listed the definition here. I won't read it to you, but feel free to check it out yourself. So what does EMTALA cover? EMTALA really covers somebody who's having an emergency medical condition and someone who comes to the emergency department. So it's not going to cover you if you're out on the street. It's really if you come into the emergency room. EMTALA covers everybody that might get impacted or need help outside the emergency room. And when you think about the definition of an EMTALA, which I'll go over shortly, it covers people who need stabilization. So even though EMTALA is really a law that impacts those who come to the emergency department, because it requires stabilization of patients, EMTALA really covers those patients who were not stable in the ER and left the ER to go to a specialist or someone else to get stable. So a lot of times people who might need acute psych help and are transferred out of the emergency department and go up to maybe the psych unit of the hospital and could be there for quite a while. They really are still covered by EMTALA because they haven't been stabilized yet. Just a little history. EMTALA was called the anti-dumping law. And what that really was meant to do was prevent patient dumping. Patient dumping is really when hospitals either refuse to see a patient or they have a patient that's in the ER that they really don't want to serve and they would kick them out. Was this a huge problem? That's still contentious. There is data to show that there was quite a bit of patient dumping. So at a minimum, Congress sought to require basically a medical screening and examination and treatment to ensure that there was not this patient dumping. As a result, some argue that state and local governments stopped providing responsibility for some of these folks who were indigent. Maybe they were the homeless population, or a population of mental health folks who would access a lot of services provided by the state and local governments. Basically, the argument is that the responsibility was put onto emergency rooms to take care of these folks, and therefore, once that law came into effect, kind of the local providers of some of these other types of care were able to not provide it anymore. Whether or not that's true, you can look at some of the data that is out there. So who pays for the uninsured? Everybody does. Hospitals who don't get paid for the uninsured that treat folks in the ER and ultimately in the hospital can spread those costs to other services that the uninsured or folks with private pay for. So they make up that cost in increasing the cost of everything else. Or they declare it as a loss on their taxes. I won't go deeply into that, but as a business, at the end of the year, when you state you have a profit and you pay taxes on it, or you state you have a loss and you don't pay taxes, if you have a lot of uncompensated care from your emergency room, you could basically say to the government, we don't need to pay taxes on our profits because we didn't make any this year. So there can be multiple ways that the uninsured get care, and that cost gets spread to other folks. There is another situation where patient might be insured, but the plan either retroactively denies a claim based on maybe the diagnosis, or whether or not maybe the patient paid the premium on time. So the patient does basically become uninsured by the time the bill rolls around. So that can often be kind of a situation where there's an uninsured person, even though maybe they were insured at the time. So EMTALA has three major obligations. The hospital has to treat an individual who comes into that ER and requests examination or treatment of a medical condition. Now what they have to do is a screening. This screening cannot be delayed to inquire about whether or not there is a payment source. And emergency departments must also post signs conspicuously in the emergency room that this is a requirement. Second, if an emergency medical condition exists, treatment must be provided until resolved or stabilized. So that goes back to a couple of slides ago, when a lot of people consider EMTALA an emergency room law, but because there's a requirement that it's resolved or stabilized, this can impact other departments of the hospital in the hospital system. So although it feels like an emergency room law, it can impact a lot of the hospital. If the hospital does not have capability, third, to stabilize the emergency medical condition, an appropriate transfer to another hospital is required. So EMTALA impacts other hospitals admitting a patient if that first hospital does not have really the capability of treating them, which is often why smaller hospitals would have to transport patients to bigger hospitals, because maybe they cannot fully treat the patient's complex needs. EMTALA basically says that bigger hospital with more capability has to take the patient from the smaller hospital. So what happens if hospitals don't follow EMTALA? Well, they can get a $50,000 violation. And there is a threat that basically the federal government will say, fine, well, we won't pay you Medicare dollars anymore, which often is a big chunk of the money that they receive. So it can be a fairly big violation, slap on the wrist. Between January 2013 and March of 2015, there were about 29 EMTALA violations across the country. Now, when you think about how many hospitals and patients there are across the country, that's really not many. Some have argued that EMTALA has basically become the national healthcare policy for those folks who don't have health insurance. And I would say that's somewhat true. Hospitals are now forced to treat whether or not they're going to get reimbursed for that. And so it is somewhat of a de facto healthcare policy for uninsured. Now, what the Affordable Care Act did, so Obamacare, recognized that this was basically an unfunded mandate, which means this was a law that required hospitals to treat people, even though hospitals might not get paid for it. So the Affordable Care Act tried to create less uncompensated care, less people without insurance. And so they created the market, they created these exchanges, and they also created a penalty for folks who would go the whole year without health insurance. These were a couple tools that they used to try to make sure everyone had health insurance. If you're not familiar with the tax bill that was passed last year, it made changes so that tax penalty that individuals might have to pay for not having insurance is going away. Didn't eliminate that in 2018. It will go into effect 2019. So there still is the tax penalty this year, which I think is about $700 per adult at the end of the year if you didn't have insurance for the whole year. Let's use our policy analysis tools to look at EMTALA really briefly. Costs. So costs, a lot of people get confused that, there's EMTALA, so I can get treated at the emergency room if I don't have insurance and I don't have to pay for it. No, that's not actually true. You still get billed if you don't have insurance, right? So a lot of people can go into bankruptcy because of this. You can still get billed, but basically you can get care without being forced to pay. Cost to the hospital, really high. They have the same costs, they still have to provide the care. Quality, does it impact quality? Well, you can argue both ways. Access, well, this creates universal access to patients, whether or not they can afford to pay for care. And evaluation, I thought about having a discussion post where you look at evaluation under EMTALA, but I wanted you to try something else. But go look and see how EMTALA impacts hospitals. There's actually not a lot of data out there. In fact, if you go out there and look for EMTALA violations, I bet you're going to have a hard time finding any. So, evaluation under EMTALA, I would say, is not that great. So that's week 8. Let me know if you have any questions, comments, or concerns. And don't forget that you have an assignment due this week, which is your final policy brief outline. Thanks, and have a great week.